Hello there, Tony Meekum back at it again. In this video, we're going to do soft tissue calcifications. I think this one's a little fun. It's really just kind of identifying calcifications, where they came from. So it's a bit different than other topics we've done. We're not just talking about radiolucencies and radiopacities. And so we're outside the bone in the soft tissues of the face and neck. Almost everything is going to look white. It's calcified, right? Roundish, asymptomatic. So the whole game here is going to be identification. Where it is a huge part. What shape it is, does it have layers, and is the patient feeling anything? So if you take one habit away from this video, make it this. When you see an opacity that isn't in bone, ask first location. Location does most of the diagnostic work on this topic, so shape and internal pattern are going to finish the job. Here's the outline. We'll spend some time on dystrophic calcifications, which is a big part of the show, and then idiopathic ones. We'll quick mention of metastatic calcification, then we'll finish with ossification and a set of practice cases at the end. Don't try to memorize this as a list. By the end of the video, you can immediately identify when you see these calcifications and what it's most likely to be. First of all, vocabulary, because these two things shouldn't really be used interchangeably. Calcification is deposition of calcium phosphate salts in the soft tissue in an unorganized fashion. So think of it just as mineral dumped into tissue, no real architecture. And calcification comes in three different flavors. Dystrophic, which is mineral laid down in degenerating, diseased, or dead tissue. This is by far the most common. And in those cases, serum calcium and phosphate are going to be normal. Then we have idiopathic, which is deposition in normal tissues, also with normal serum levels. And then there's metastatic, where minerals precipitate because serum calcium and phosphate level is actually elevated. Something systemic is driving it, something like hyperparathyroidism or chronic renal disease. And because it's systemic, it tends to be bilateral and symmetric. Then ossification is a little bit different. That's mineral deposited in an organized, well-formed fashion. It does resemble real bone. Sometimes it even has a cortex and marrow space. And so this is where terminology is really important. Something like a ligament, the stylohyoid ligament, which we're going to see calcified pretty frequently, you shouldn't refer to as calcified when really it's ossified. So you should call it the ossified stylohyoid ligament. All right, so starting with dystrophic, since this is the workhorse category of the topic, dystrophy just means a tissue wasting away. So dystrophic calcifications is mineral going down at a site of injury. Tissue's degenerated or dead, local phosphate concentration goes up, and the local environment turns more alkaline, so mineral precipitates right there. It's localized to the site of injury. That's why it's not typically symmetric and bilateral in any real predictable way. It's just where the damage occurs. And so where do you find it? Well, any sites of chronic inflammation, dead or dying tissue, in this case, inside the wall of a long-standing cyst. Clinically, it should be asymptomatic. If it is superficial and large enough, you can sometimes palpate it, but the patient usually has no idea it's even there. Radiographically, the appearance is variable. It can be anywhere from fine granular flecks or a larger discrete radiopaque particle. Rarely is it going to be bigger than 5 millimeters. So when you see a small, ill-organized fleck of opacity and soft tissue with no particular shape to it, general dystrophic calcification is a reasonable read. All right, now the named entities, starting with the first one, lymph node calcification. This is dystrophic calcification inside a chronically inflamed node. Something happened to that node, either current or in the past. A classic example is tuberculosis, also sarcoidosis, cat scratch disease, rheumatoid arthritis, progressive systemic sclerosis, lymphoma, and fungal infections. This is an incidental finding. Occasionally they are palpable. Location is most of the time in the submandibular cervical, less commonly in the preauricular or submental, but this could occur anywhere you have a lymph node. That's why we have a picture of these lymph node chains to remind you of where they are. So on a panoramic, the submandibular typically puts that at or below the inferior border of the mandible, or posteriorly back near the spine. The appearance is the fun part. It's well-defined, irregular, lobulated. Classic descriptor is cauliflower appearance. It's a collection of spherical or irregular masses, and it can be a single node or an entire chain. Occasionally you'll see lamination. And so the differential for these is basically one of two other things. Sialolith can be a really similar location. You've got the submandibular is the most common location for Sialolith, also for lymph node calcification. But Sialolith typically has a smoother outline. More importantly, the patient has symptoms with Sialoliths, obstructed duct, pain and swelling at mealtime. Sialography could really settle it. Phlebolyths, on the other hand, are usually smaller, usually multiple. And phlebolyths typically have that concentric radiopaque and radiolucent ring pattern. So the management for these, they don't typically require treatment, but you may want to investigate the underlying cause. Maybe they have one of those diseases or had a history of an infectious disease in the past. And tonsilloliths, probably the most common thing that you're going to see as a dentist. Repeated bouts of inflammation enlarge the tonsillar crypts. Organic debris accumulates inside those crypts, and that debris becomes the nidus for the calcification. Clinically, they're hard, round, white or yellow projections, most commonly in the palatine tonsils, as we see here. Usually asymptomatic, but patients can get occasional pain, a foul odor, foreign body sensation, or difficulty swallowing, and incidence increases with age. On a panoramic, they're going to overlap typically the mid-ramus, part of the mandible, either anterior or posterior to it. Multiple small, well-defined radiopacities cluster together. And so look at the positions here. One example shows it sitting anterior to the ramus, the other posterior to the ramus. Of course, when you have 3D, you can really appreciate the exact location of it, usually just on the side of the airway. And here we can see aligning multiple tonsils. So we have a ring of tonsils that outline the oral airway. That's called the Waldeyer's ring. And so with 3D imaging, it really definitively answers the question of where it actually lies and can really tell you that it's tonsillolith. And this is what we mean by foreign body sensation, maybe not this severe, but a large tonsillolith genuinely can feel like there's something stuck in your throat because functionally there could be. All right, Cysticercosis. This one's pretty uncommon. You may never see this in your practice, but it is a great board-style entity because the appearance is pretty distinctive. And so the larval form of pork tapeworm hatches inside someone's stomach, enters the bloodstream, and can distribute throughout the body. Cysts will develop in the skin, muscle, brain. Presentation ranges from nothing at all to GI upset, headaches, and seizures. So the calcification shows up years after the initial infection, after the parasite dies. They typically present as well-defined elliptical radiopacities. They have a real propensity for the muscles of mastication, which is why they could land in our field of view. But this is what they'll look like, just well-defined, round, scattered radiopacities. And then this one is a big one. I would say as far as a clinician, a treating dentist, this is the biggest one to identify that can affect the patient's health. So atherosclerotic plaque is accumulation of degenerative material within the tunica intima, or the inner layer of the arterial wall. That plaque undergoes dystrophic calcification, and that's when we can see it. So it typically develops at first at arterial bifurcations, anywhere there's turbulent flow. That means in the carotid bifurcation puts the calcification right near the greater cornu of the hyoid, and adjacent typically around the C3 or C4 level. The appearance is multiple, irregular, vertically oriented linear calcifications. And so I said this is important. The action you need to take is refer to a physician for further investigation. And I want to be clear about why. There's plenty of case reports of patients with calcified carotid atheromas on panoramic images who turned out to have clinically significant stenosis and elevated risk of stroke. And so we don't have as a controlled study proving that calcified atheroma on a panoramic is an independent risk factor for stroke. So the honest position is you're not diagnosing stroke risk. You're finding something that warrants a further evaluation by a physician, especially a patient who already carries cardiovascular risk factors. So refer, but try not to alarm the patient. And so this slide just shows the anatomy of where to look for it. The common carotid artery comes up, bifurcates into the internal and external right around C4 or maybe the C3 level. So this is the spot. When you see linear calcifications in that window, posterior and inferior to the angle of the mandible, that's your carotid. And it may occur slightly below the hyoid bone or above the hyoid bone. Anywhere there's an artery, you could see these type of calcifications. All right, here's some examples. And you've got to compare these with, is it just a part of the hyoid bone? Is it part of thyroid cartilage calcification, which we'll talk about later? But it's really irregular, ill-defined, kind of goes above and below where the hyoid bone is. A lot of those things are telling you that this is a carotid atheroma calcification. And then, of course, if you have the 3D view, here's a medical CT showing these calcifications, outlining right where you would expect the carotid calcification, and then following up the external carotid here as well. Here we have a bilateral, fairly thick, dense calcifications. And then this is a different type of disease, but it still falls in the realm of arterial calcifications, Munkenberg's medial calcinosis. And so this is age-related degeneration and calcification of the tunica media, or the middle wall of the vessel. And this one is typically associated more with peripheral vascular artery disease. And so these examples here, obviously outside of our field of view, we have an ankle here, a foot, then we have the hips and the femur. But where we're most commonly going to see it is in the facial artery. And the distinguishing factor about this is, notice instead of in the carotid artery, those atheroma calcifications, it looked more irregular and dense, kind of big accumulation. These are just more faint calcifications around the periphery, and that's what they call the pipe stem or tram track on plain films. It'll appear circular in the 3D cross-section. And so again, this requires a referral. It's a little bit different. You don't have to specify. You can just say arterial calcifications. Maybe you can mention that it looks more like medial calcinosis as opposed to atherosclerotic plaque. But these are people who are more at risk of peripheral artery disease. And these are a couple of really good examples from a paper that was written a little while ago showing the difference between the medial artery arteriosclerosis and calcified carotid artery, which you typically assume are going to be down around the neck, around the C3, C4. But then you get the medial arteriosclerosis up more superior. And then you have examples of medial arteriosclerosis as well. And then this is just the styloid process. And so this is for comparison. What does that look like? That's a mandible, cropped panoramic image, something crossing the body of the mandible. And so that's facial artery calcification. Does it look more like the medial or the atherosclerosis? Well, it's more the tram track, more the medial arteriosclerosis. And then here for comparison, you have this irregular calcification in the posterior neck, right around the level of C3, C4, and that's your atherosclerosis. All right, now we're getting into category 2, idiopathic calcification, which is deposition in normal tissue with normal serum calcium and phosphate. Nothing diseased, nothing elevated, it just kind of happens. And this is considered more of a physiological process. Basically, think of any cartilage can calcify over time. So think of where the thyroid cartilage is. And there's this superior horn that kind of creeps up toward the posterior aspect of the greater horn of the hyoid bone. You have this ligament between the thyroid and hyoid, the thyrohyoid ligament. And really that can calcify anywhere, but it just tends to calcify more where there's definitive cartilage. And then there's this small piece of cartilage here called the trapezial cartilage. And so that has a tendency to calcify. And so look for that. If you have an image that shows far enough down, you see the entire thyroid cartilage, this may calcify anywhere along there. More commonly, you're going to see the superior horn. But look for that small little floating calcification, and it looks like a grain of wheat. That's actually where it gets its name, the trapezial cartilage. So we'll see examples of both of these. In this lateral ceph, it looks more like just an irregular calcification of the cartilage. But it's that location that's right on the thyroid cartilage that tells you this is just cartilage calcification and not arterial. This one is really well defined, and so you can see that superior horn of the thyroid cartilage. And then we also have trapezial cartilage calcifications, really well defined in this case, nice and smooth bordered. And so now let's talk about Sialolith. This is where if you have slow salivary flow, the physiochemical characteristics of gland tend to form a nidus and mineral deposits around it. So demographics, middle-aged to older, more common in males, 70 to 80% are solitary, but they could be multiple. That's just more rare. And this is the one entity in the entire video where the patient has real symptoms. And so I want you to hang on to that. Pain and swelling in the floor of mouth. And it's worse during meals. Salivation ramps up, the duct is obstructed, and pressure builds up. That's what causes the symptoms. Every other calcification we talk about in this video is asymptomatic. And so if the patient has mealtime pain and swelling, you're looking for a Sialolith. Location, typically the submandibular gland, that accounts for about 90% of these cases. And of those, roughly half are going to be in the distal duct. 20% are going to be proximal, meaning closer to the gland itself, and then 30% will be within the gland itself. The appearance is going to be cylindrical, round, or fusiform, meaning cigar-like shape or football shape, typically smooth and radiopaque, homogeneous, or sometimes they look layered. Then just be aware some of them are so poorly mineralized that they appear radiolucent, you won't really see them on a radiograph. So differential is everything else we're going to talk about in the video, and the tiebreaker is going to be symptoms. But a lot of time I think the smooth, round opacity, when it's fusiform shaped, that really tells you that it's a Sialolith. As well as the location, the classic location, floor of the mouth, submandibular gland, remember the Wharton's duct. This could occur with other glands as well. Sometimes you'll see it with the parotid gland. It's just a lot more uncommon. And so this is a classical presentation where we have an occlusal video. That fusiform shape looks like a cigar in the floor of the mouth. Nice and smooth and well-defined, homogeneous. This one's a little less calcified, but still it's following the path of the Wharton's duct. And just based on that, you can tell this is a Sialolith. This one, it's tough to tell, is it coming from the bone or is it in the floor of the mouth until you get that occlusal view. But based on the appearance, very smooth and well-defined, sometimes a little bit layered, so it doesn't have to be completely homogeneous. This is a fun one. Someone was actually able to remove his own, and you can appreciate the actual size of these things. So we'll come back to this in the salivary gland disease lecture.